Hello everyone, good afternoon. Welcome to this very special live event, Overcoming Knee Pain, Let's Keep You Moving. This event is courtesy of Banner Health. I'm Eric Sperling. I'll be your host and moderator today. And we do have some of the top minds in the field joining us today from Banner Health to discuss this important topic. Dr. Samuel Ashby, Dr. Rafael Buerba-Siller, and Dr. Vibatsu Amin, all with us. Excited to have them live in studio, and we look forward to chatting them in just a moment. First though, got to reference this. Housekeeping items. Because this is a live streaming event, if the stream goes down at any time or you're having connection issues, we recommend just logging off, try logging back on, that tends to fix it. This event, most importantly, will be available to stream and share on demand once the show is over. Here's how it's going to work. We'll be bringing our doctors up one at a time to go over some key items related to knee injuries and the patient journey, and then we'll have a panel discussion with all of the doctors. So we invite you watching at home, and I know there's a big audience right now, submit those questions using the chat feature on the side of your screen, and we'll try to get to as many of those questions as we can. But for now, it's time to get the show started. Let's meet our first doctor.
My name is Vibatsu Amin, and I'm an orthopedic surgeon specialized in hip and knee replacements at Banner Health. What prompted me to go into orthopedics is the difference I can make in patients' lives. As a joint surgeon, I'm able to help patients return to the life they want to live, and there's nothing more satisfying than that. What's unique about my approach is that I pride myself on listening to every patient and tailoring individualized treatment plans. When it's time for surgery, I use robotics and advanced technologies to give you the best possible outcome. For hip replacements, I use the anterior approach to get you back on your feet as soon as possible. Direct communication is vital to a successful outcome. It's crucial for me, especially when undergoing surgery, to understand your goals and expectations so I can help achieve them. Trust is very important between a patient and a physician. You have to trust that I'm doing everything I can to help you, and I have to trust that you're doing everything to aid your recovery. That and shared goals and expectation setting are the cornerstones of a successful patient-physician relationship. I would want patients to say that they felt listened to, prioritized, and that I treated them like they were a member of my family.
All right, here he is now live. Dr. Amin is with us in studio. Thanks for being here.
Happy to be here.
All right, we have these pre-production calls, these pre-discussions before we ever do one of these live broadcasts. And one of the things you said your patients bring up, it's kind of the first interaction you have is arthritis. The topic of arthritis always comes up. So I'm going to ask you a couple of questions around arthritis. First, how do we define arthritis?
Sure. Arthritis is simply defined as the loss of cartilage in your knee.
Okay.
And as you lose that cartilage, you start getting pain, inflammation, and swelling as a result of that. And everything that kind of comes after is defined as arthritis.
So let's talk about the cartilage then in your knees. And you hear about arthritis at different ages, right? But when do you primarily see the cartilage start to dissipate in the knee?
Sure. It's different for everyone. Most commonly, early would be in your 40s, but on average in your 50s is when you start losing that cartilage. But it can be affected by many other things like genetics and the type of activities you do, things that have repetitive motion. So it can be different for everybody.
And how do you diagnose something like that? Is X-rays, what's the, as soon as the patient comes in and says, I think I've got arthritis in my knee,
Sure.
What do you do?
The first thing we do is X-ray. So when you come into the office, we'll take a couple different X-rays of your knee to see how much cartilage you have left or if there's anything else going on that could be causing pain. And then physical exam. So when we see you, we'll see how your knee moves, where it hurts, and that in combination with talking to you really helps us determine if the arthritis is the cause of your pain.
And we're going to talk more about ways to prevent arthritis, ways to treat arthritis, but what are some of the common things I hear? The more mobile you can be, the more movement you can bring into your life, the better chance you have of avoiding arthritis. Is that true, or is that sometimes the cause of the actual arthritis?
No, I think as a general rule of thumb, the more healthy lifestyle you live, the better chance you have of preventing that arthritis. Weight loss and maintaining a healthy body weight can be very helpful. Each pound of weight that you gain is 4 extra pounds of pressure on your knees. So
say that one more time.
Each pound of weight that you gain is 4 pounds of pressure on your knees. So even small changes in your diet or exercise can really help go a long way.
All right, Dr. Amin, great information. Stick around. We're not done with you yet, but for now, let's meet our next doctor.
Hi, my name is Dr. Rafael Buerba, and I'm a sports medicine and shoulder surgeon at Banner Health. What is unique about my practice is that I like to take an individualized team approach. No patient is the same. Every patient has different needs, different goals. One of my goals as your physician is to have conversations with you regarding what are your goals, what do you expect to do, and what is your expected level of function. One of my goals is to have my patients say that I took great care of them by listening to each of the patient's individual needs. It truly makes me happy when patients come back to me and they tell me that they're able to return to their activities pain-free.
All right, joining us live now, Dr. Buerba-Siller. Thanks for being here.
Thank you for having me.
All right, we're going to talk a little bit about the sports side of things, the sports injury side of things. Or I guess, what are some of the most common knee injuries that you see in your practice?
Right, well, yeah, people definitely get their knees injured quite a bit playing sports. In the high school ages, one of the most common things we see are ACL tears.
Right. So let's talk about ACL tears. You know, I'm sure a lot has changed as far as when it comes to treating ACL tears. In your experience, what kind of advancements have you seen, and how are ACL tears treated today?
Correct. Well, ACL tears have definitely changed significantly in the way they're treated. Back in the day, people were just putting the graft somewhat vertical, but now with the new instrumentation we have, we're able to get a more anatomic ACL reconstruction and put it in the right spots. And that has definitely helped patients have more stability in their knee. And also it has shown that it can actually prevent some arthritis onsets. Other things that we have done, especially for people that have really unstable knees, we have started to stabilize the outside of the knee with a procedure called a lateral extraarticular tenodesis, or LET.
Okay. And
that has, it's a little bit of a longer surgery, but especially for people who have failed their ACL twice, it has significantly reduced the chance of a re-tear. Nowadays, we now have a procedure where we can, sometimes depending on the type of tear, we can actually repair it and add basically like a matrix on it to stimulate some healing. And it's one of the newest ACL procedures. So definitely a lot of options, a lot of different grafts as well. It just depends. Like if you're an older athlete, maybe it's better to use a cadaver allograft. It's meaning we take basically a piece of cadaver from a dead person to stabilize the knee instead of taking your own tissues to do that.
Why is it better for an older person to use?
Well, studies show that the outcomes for once you're not involved in super heavy athletic activities, that they're equivalent to using your own tissue. And it's also less morbid. You know, when you get, for example, a bone patellar bone ACL reconstruction, we have to take bone from the patella, take tendon from the patellar tendon, and bone from the tibia tubercle, and then use that as the graft. So it's, you know, a little bit of a sizable incision. Nowadays, we've been having a pretty good outcome using the quadriceps tendon as a graft. Wow. But again, it's also, you know, taking like spare parts from your knee to reconstruct it, whereas using a cadaver graft, good outcomes and a little bit of an easier recovery, but it does take a little bit longer for the graft to integrate.
Interesting. So, I mean, we've heard about ACL tears for a long time, and in your world now, that we were saying the innovation, the technology is getting so much better, and that leads to either better outcomes, quicker recovery. And it was interesting, I heard you just talk about, like, you know, the ACL tear potentially creating arthritis down the road, and the ability to create and heal that ACL will ultimately do a better job of preventing arthritis, right? That's the...
Yeah, that's correct. So when you have an ACL tear, your knee's unstable, and over time, actually, the medial compartment inside of the knee starts to wear out a little bit more quickly because the meniscus on the inside of the knee is a secondary stabilizer to the knee. So once the ACL is out, the meniscus is seeing more contact pressures, higher risk of injury. So, and then once the meniscus is gone, then that leads to cartilage wear, eventually some arthritis.
All right, stick around because we're going to talk much more about recovery, but for now, let's meet our third and final member of the panel today.
Hi, my name is Sam Ashby. I'm an orthopedic surgeon specializing in joint replacement surgery at Banner Health. I became passionate about orthopedic surgery after seeing patients with dysfunctional joints re-engage in their quality of life. In my practice, I combine state-of-the-art robotic techniques, minimally invasive approaches, modern pain management programs, and rapid recovery to improve patients' quality of life. Patient-physician relationship is based on honesty, trust, and understanding our common goals. Open communication is essential for me to understand my patients' needs and help them achieve their goals. I hope that my patients can share with others that they felt listened to and that they received excellent care.
All right, now it's a party, as you can see. Welcome to the stage, Dr. Ashby. Good to have you here.
Thank you, thank you.
All right, let's talk a little bit about things that can be treated when we're talking about knee pain, non-operative things. And there's something, there was a term, I had to actually look it up. It's atraumatic knee pain. It's not like a traumatic injury, but atraumatic means something of lesser, like just destruction in there, right? What's
without something being torn, disrupted, and I think, where we live, we have great weather, we have very active aging population. We have people that are getting into things like pickleball and all kinds of different recreation. You end up putting a lot of strain on your joints, and sometimes that ends up translating into things like iliotibial band syndrome or pes bursitis or inflammation of tendons around the knee that are causing pain. Not necessarily destruction of the joint, but just more of a protest from that joint, letting you know, hey, you're pushing me a bit here, and that's something that we see in the practice, and it's a good opportunity for us to be able to help people out non-operatively, sometimes physical therapy, things along those lines.
Yeah, we were just talking about ACL tears, like in the work that needs to go into repairing an ACL tear. We're talking about these non-operative procedures now. What are some of the other things besides physical therapy that you treat your patients with if it doesn't require surgery? Yeah,
so the things that I try to use with my patients, I'm looking at traditional medications. I'm looking at injection options, looking at home exercise programs. Sometimes talking with patients about alternative supplements that can also help them out. Anything we can do to try and restore some of their quality of life, and I think those are helping out.
You mentioned injections, and we were just talking to Dr. Boer-Basiller about some of the advancements in ACL procedures. Are there similar advancements when we're talking about injections? Anything new over the last maybe 10 years that you've seen that's been really successful?
Well, I think some of the things they're working, so different types of injections we're talking, probably the most common that most people have heard of are going to be things like steroid injections, and I think the gel or viscosupplementation injections have been pretty popularized, I think. Some of the things that are probably maybe a little more niche and maybe we're continuing to work on increasing their efficacy are going to be things like platelet-rich plasma injections and also stem cell injections. Okay. Are they miracle workers at this point? Not yet, but we're working on that.
And that's what people want, right?
Yeah, exactly.
Give me the stem cells.
That's what we all want.
We'll be back in 2 days and ready to go. I just want to thank our live audience because we're getting a lot of great questions coming in. Again, a reminder to use that chat feature on the side of your screen. We will try to get to as many of those questions as possible, but we're going to move this discussion now into the recovery side of things. And doctors, you guys can kind of weigh in if you want. I'll just kind of throw the question out there. Talking about recovery, as things get better, as we talk about minimally invasive procedures, some of these are outpatient procedures. What's recovery time like? And I'll just give an example of somebody mentioned an MCL tear and fixing that. What's recovery time like for these minimally invasive procedures now?
Well, it varies a lot on the type of surgery that's done. For example, like if it's like an MCL sprain, sometimes it's just a brace for 6 weeks and do therapy. But, people that have an ACL tear, that's a little bit more involved because it includes a lot of therapy. And the goal is to get the patient or athlete to go back to the things that we're doing prior to the injury. So sometimes for a lot of our football players, soccer players, around the 9-month mark is when we do a return to sport test. And at that point, if they pass, they're good to go. But sometimes, pending there's other things like meniscus and things like that, it can take a little bit longer. But on average, about 9 months to 12 months to get back to playing sports after an ACL injury. And we do it that way because back in the day, the thought was that it was about 6 months. But then people that went to sport too early had a higher return rate.
Mm-hmm. One of the procedures that I'm sure you guys get questions a lot about, full knee replacements when it comes to recovery. Who can handle that question? How long is recovery from a full knee replacement? You look excited to answer this question.
It depends person to person, but The first couple of weeks is typically just about getting your pain controlled. After that, it's really about building up your strength and getting your motion back. So you really have to work closely with physical therapy through at least 3 to 4 months. So I would say the average recovery would be 3 to 4 months, but you're going to see improvements from until 9 months to a year. So it can take quite a bit of time for your body to return to normal.
But we're talking about, ACL 9 to 12 months, knee replacement, you're saying 4 months, could be 12 months. So and as you described earlier, it is patient to patient. The implants, when it comes to knee replacement, because I know that you guys get that question a lot, how has that changed over the years? And are we seeing knee replacements in the younger population because of the advancements in implants?
Definitely. Implant science and our understanding of materials and what metals these implants are made out of has only gotten better over time. So there's no real age cutoff on who can get a knee replacement at all. And we expect these implants, for the most part, to last your life.
Implant science, I like that. Go into a little more detail on implant science. It's more, but it's, there's more than just the device itself, right?
Sure. So when you get a knee replacement, we cut out some bone from your femur and tibia. We put metal on both sides, and we put a piece of plastic in between. In the past, that plastic used to show signs of wear at long-term follow-up, but as that manufacturing, and there's certain things that you do to that during the manufacturing process, have gotten better, we aren't seeing those changes anymore, so these implants are lasting longer.
What about robotics? How are robotics being used in knee surgeries now?
Yeah, robotics is a tool. There's so many different tools that we use to try to decrease, the recovery time on these procedures. You talked earlier about, the recovery time on these procedures. I think the two things that we can do to try and to advance that for patients, one is how minimally invasive can we be with it by disrupting less tissue. There's less time for them to heal. And then how can we manage inflammation post-operatively in order to allow that to return back to a normal state. And so that's why I say I think minimally invasive type procedures, I think implants that mirror the anatomy of the patient is helping to respect soft tissue movement. And then I think robotics, at least in I think Dr. Amin, in my experience, robotics has helped us to violate less and less of the soft tissues, be able to respect that envelope, and that I think really helps with recovery and sort of keeping things state of the art.
That's great. I mean, across the board, when you pull out from this conversation, it sounds like just surgeries are getting better, the recovery time's getting better.
Yes.
Implants are getting better.
Yeah.
So the patient journey for knee surgery is much improved from where we were maybe 10 or 15 years ago.
Yeah.
All right. We've got to get to some of these questions coming in because there are some great ones. Again, I'm going to read these cold, and you guys feel free to jump in. Could eliminating certain nerves around the knee eliminate arthritis pain? Go ahead. Well, I can feel it.
Yeah, some of our Banner surgeons have been pioneering basically like a nerve surgery where it's almost like the nerves are getting rewired in the knee, where some of the pain fiber nerves become more like motor nerves. And it's relatively new, but it has shown some promising outcomes on that. So it doesn't cure the arthritis, but it can make the pain somewhat more tolerable.
Interesting. Anybody else want to jump in on that question? You good? Pass. All right, let's talk about maintaining healthy knees for a minute, because here's a question coming in. What are some of the best exercises and dietary strategies to maintain healthy knees? And again, wasn't that you that referenced that, for every, 4 pounds?
Every pound is 4 more pounds of pressure on your knees.
Yeah, so let's talk about this important question then. Exercise, diet, what can you do?
I think exercise-wise, keeping your quadriceps strong and keeping your hamstring strong. The stronger those are, the more they're able to support your knee and the less pressure you'll feel in there. So, and most exercises that you do, whether it's going to formal classes or going to the gym by yourself, you can focus on those type of muscle groups. I think that would help long term.
Diet and exercise?
I think low impact activities, and cycling and swimming are typically the arthritic patient's friend.
Okay.
Yeah.
Any recommendations? Exercise, diet, maintaining healthy knees?
Well, certainly a lot of patients, their kneecap kind of tends to go a little bit more towards the outside. So definitely doing strengthening of the inside of the quadriceps can help realign the kneecap a little bit better so that it stops putting that much pressure on the outside of the knee.
Okay. I always get caught with stuff like this because you said I want to strengthen my quads, I want to strengthen my hamstrings. First thing I want to do is jump in the gym and do squats. Is there something that's maybe too extreme? I love the swimming. Is that maybe too much if someone's just trying to maintain healthy knees?
I think letting your body be the guide on that stuff
Okay.
is the best rule of thumb. So you can do whatever you want, whether it's low resistance, high resistance, but if you start having pain and are noticing that it's starting to affect things negatively, then you've probably either done too much or
Okay.
shouldn't be doing that activity.
Okay. Good tip, thanks. I'll notice that when I'm in the gym trying to do squats to strengthen these. All right, we did talk a little bit about stem therapy before. You know, we wanted that miracle cure, but can you talk a little bit more about stem therapy, how it's being used for knees?
I don't really use it.
Yeah, we can talk about it a little bit. So in the sports medicine world, we use a lot of biologics.
Okay.
Stem cells are still somewhat experimental. Now they are available at Banner with our group. But our version of stem cells at Banner, we call it bone marrow aspirate. So essentially, we harvest some bone marrow from around the hip area, and then that gets processed through a centrifuge. It's a layer in the bone marrow that has, some of the stem cells, and that gets injected back into your knee. Some patients have had excellent results. It is somewhat pricey, unfortunately not covered by insurance yet, but it's still on the experimental side. Is it harmful? Unlikely. Does it have potential benefit? I would say yes.
Okay, great answer. Let's talk about the best course of action for someone with early onset osteoarthritis. You guys are tough to read.
I think
sometimes.
combining a lot of the things that we've talked about here, and also combining like our specialties here too. So I think with a knee that's very, very early in that arthritic stage, a lot of times we're talking about the physical therapy, the home exercise program, the low impact activities, anti-inflammatories to try and keep those inflammatory levels down, keep patients down. I think just doing all that, and then probably the biggest is consistency too. Just being really consistent about, and then and diet. I think if you can combine all those, you're going to slow things down. Now, do I see a marathon runner come in every once in a while, the fittest guy you can see, and he's got a trashed hip or a terrible knee? Absolutely, but I would say by and large, though, it's people who are consistently taking care of their health, like we've talked about here, are going to probably give themselves the best chance of having a long-lasting, original parts, long-lasting original parts.
I think it's a pattern we're going to keep hearing, right? It's the diet, it's the exercise to maintain these healthy knees. And again, thank you to our live audience. Great questions coming in. We'll try to get to as many as we can. Here comes a few more. What is the best treatment for patella that slips out of place?
Well,
yeah,
that's kind of like a surgery I do a lot. That's a little bit of an involved question because I think patellar instability is one of the more complex knee surgery topics.
So what is that? What's patella instability?
So basically, means when the kneecap kind of pops out of place towards the side, and sometimes it has to do with a few things. Sometimes people's alignment's a little bit off. Sometimes, they had a freak accident and they just injured the structures that stabilize the knee. So usually we have to get some imaging, like x-rays and an MRI, and then take some measurements and figure out what's the best surgery. Sometimes if it's not too bad, it's just physical therapy and a brace. Sometimes if it's like a tweener, you can do an MPFL reconstruction where basically you use a graft to pull the kneecap over. Sometimes if the alignment's completely off, you have to basically cut the bone and shift it, and sometimes add a graft to stabilize it. Wow. So that one requires a little bit more workup, but we also have to rule out any cartilage injuries because when you pop your kneecap out of place, sometimes you slow off like a piece of cartilage, and we have to address that as well.
We were just talking to Kelsey, our floor director, the other day. She had that. So is this, you said you do this a lot, is this common? It's a common thing?
Yeah, it can happen a lot in athletes. Also, just, and we see it a lot in women too, just because the alignment, tend to have a little bit of wider hips and then the knees go down, so the kneecap's not tracking well, and it tends to go off to the side. But we see that sometimes in our athletes too. They have, the knee twisted the wrong way, kneecap's out of place. And then after that, we have to assess why did it pop out of place. And sometimes it's because the alignment was off, puts them at risk for this happening again.
All right. Anybody want to add anything? Covered it all. All right. Let's talk about the difference between viscous injections, I think that's what I'm reading, and cortisone injections.
Sure.
Okay.
There are two different injections. The cortisone injections have been done for many, many years. And basically, it's like putting an Advil pill right in your knee. It just calms down the swelling, the inflammation.
Great analogy, yeah.
And most people get some relief from them.
Okay.
The question is how long. You can get 2 weeks of relief, it could be 3 months, it could be a year. So you can only do those every 3 months, but people typically do find some benefit from them. The gel,
Why can you only do those every 3 months?
if you do them too often, you can start damaging things inside the
Okay.
knee, like your cartilage, ligaments, things like that. So we don't like to do them more frequent than that.
Okay.
And then another thing to note with those injections is you can't have one within 3 months of surgery.
Okay.
So if you're starting to think about wanting surgery and you do an injection and it didn't help, and 3 weeks later
Yeah,
you're
it's gonna
really
push back
miserable,
the surgery,
you
yeah.
have to wait, 2.5 months from that point
Yep.
still to have your surgery. Talking about the other injections, the gel or the viscosupplementation, those are a little bit newer, and those can either be a series of 1 injection or 3 injections that you get. And it's basically like a lubricant that gets injected into your knee, and it kind of helps your knee glide a little bit better, and that's the goal. It doesn't regrow your cartilage, but certain patients do find success and improvements with that as well.
Okay. Yeah, it sounds like a patient journey. When they come to see you, you start with some of these options, but it's good to know all of this information about, okay, hey, if I go with the injection, I might have to put off surgery.
Sure.
So it's good to know all these options. Okay, all right, this question, can you discuss shockwave therapy, and do you use it? Does anybody use that?
I don't think I've heard of
Okay.
shockwave therapy being used for knee, so I can't really comment on it.
Okay,
Yeah.
we'll move past shockwave therapy. What is the difference between a partial knee replacement and a total knee replacement?
Sure. So it's basically what it sounds like. In a partial knee replacement, we go in there and replace one part of your knee. You have 3 broad compartments of your knee: the inside, the outside, and behind your kneecap, or the medial, lateral, and patellofemoral compartments. So if you have isolated arthritis in one of those areas, sometimes we'll talk about doing a partial replacement where we just replace that area. And doing so allows you to maintain the rest of your knee ligaments, and you keep the rest of your cartilage that's healthy.
Yeah.
I mean, you don't cut that away. And in certain patients who are more active or healthier and have certain goals, we discuss that type of replacement. And then a full replacement is replacing everything. We cut off all the parts of your knee and replace it with metal and plastic like we talked about earlier.
Is recovery time the same for both of those procedures, or is it less for the partial?
The partial knee replacement patients get back on their feet faster. It's a quicker surgery. It's a little bit less of recovery. Their pain is better because we didn't have to take away all that excess cartilage and bone. They still have a lot of their native anatomy left,
Okay.
so it helps with their recovery.
Anything to add on partial versus full?
Yeah, I think one thing that's nice about partial knees, a lot of times in my practice, one of the times I'll consider is if I have a younger patient, somebody maybe in their 40s, 50s, maybe they've had either some trauma to their joint, maybe they've got poor genetics, maybe they have irreconcilable meniscal injuries that are leading to rapid deterioration of the cartilage. I like to look at, how long is this arthroplasty going to last? If I have we talk about these implants lasting a lifetime, but if you start at 40, that's a long time to ask for something that's mechanical, not biologic, to be able to, to last you. And so sometimes that can be a really good option to solve in somebody who's a little bit younger and wants to keep active. They want to keep all their ligaments and all their, all their native tissues, but get rid of pain, And so that's usually when I think about that. Are we gonna have to maybe revise that down the road, 20 years, 25 years down the road? That's possible, but I'd rather, if it was my knee and I'm younger and I want to stay active, I'd rather take the smaller procedure, have a quicker recovery, and then maybe 20, 25 years down the road, I got to consider converting that into a total knee, and then you get a primary knee again, just like you kind of almost puts you back on the right timeline there.
Sounds like so much goes into assessing the patient because of all of these different factors you just mentioned: age, diet, genetics. What is the right path? So that's why it's important to have these conversations with you guys to help patients on that journey make the decision for themselves. Let's talk about a question coming in. Any thoughts about specific anti-inflammatory supplements or food even and their effectiveness for arthritis? So another question around arthritis here.
I get this question a lot in my practice. Sometimes as a physician, it's a little bit hard to, give out very specific things based off of big studies. There's not a lot of money on the pharmaceutical side for them to create these massive studies to, fund eating more apples or something like that as a supplement to help your knees, But I would say that in my practice, patients coming back to me and us talking about, hey, what works well for you? I often see patients taking things like turmeric, and that's things that essentially are introducing an agent that can decrease inflammation and that they're happy with, and they at least provide some relief.
Okay, again, back to diet being so critical, maintaining healthy knees. Can an obese person get a total knee replacement?
Yes.
Yeah. Good question.
Yeah, I mean, I think definitely obesity actually drives some of the deterioration of joints that we see. That's one of the risk factors for wearing out your joints. And so, yeah, I mean, we treat lots and lots of patients who are obese. There are some points that we look at in some of the scientific literature that is saying that hey, above a certain point, we're starting to increase post-operative risks and complications, and that feels like part of like our role as a physician is trying to help patients understand, hey, here's the benefits, we understand these benefits and we want those, but also let's do a risk assessment and see, is that benefit going to be enough, or is this risk way too high for you? And sometimes we talk about enrolling patients in maybe weight loss programs or something like that, or using some of the non-operative things we talked about in order to help get them ready where their risk is low and that benefit's nice and high, and they're going to be very happy with their outcome.
Makes sense. Sounds like you wanted to add something to that.
No, I
Are you
agree
good?
with
That's
Cecil.
perfect. Okay. Anything? You good? All right. Next question's coming in. Here we go. And again, forgive me reading these cold. Speaking of cold, is it okay to cold plunge after knee replacement? So somebody out there likes to cold plunge.
I think it's fine, but your incision has to heal. So for the first 2 to 3 weeks after surgery, we really want that incision to heal to prevent healing wound complications and infection, which can be a really big problem in knee replacements if that happens. So once that heals and you're getting some of your motion back, it's okay to start going into bathtubs or hot tubs, but you have to give it a little bit of time after surgery.
Yeah, sounds like there's agreement on that side of the couch. Wait till that incision
Yeah.
heals.
Yeah.
Okay, is there a cure for Osgood-Schlatter disease? I think I said that right. And what does treatment look like?
Yeah, so Osgood-Schlatter's, it's basically almost like growing pains. Essentially what's happening is your patellar tendon is pulling on your growth plate a little bit, on your tibia. So for the most part, it's a self-resolving, self-limiting condition. Once the child tends to grow, it tends to resolve on its own. During that time, it's okay to take anti-inflammatories, ice, and change activities. Once you're an adult and if it's still having pain and somewhat prominent tibial tubercle, some of this imaging can reveal that there's an ossicle or a piece of bone that didn't fuse or something, and then we can do a small surgery just to take that out.
Okay, so it's not always just, it's growing pains, you get over it. If it's still causing problems, come see one of someone like yourself and get that diagnosed, right? Okay.
Correct. Yeah.
Great answer. Okay, I've got some questions that have come in ahead of time too, and I want to get to some of those because we went right into the live chat, which was great. There were a lot of questions that came in. And some of these we have covered, but again, I want to remind everybody, I know some of you are joining us live that maybe weren't here at the beginning. Let's talk about things you can do at home. We talked about going to the gym. What can I do at home to treat my knee pain? And I'm sure we're talking about things like ice and heat, but you can Google and look online all you want, but it's fun to hear it straight from you guys. What do I do at home to treat knee pain?
Yeah, I think ice, heat, elevation, activity modification. Your body. I think humans are designed for survival. So if your body's screaming at you, then don't do it. And if it feels all right to you, then you're probably going to be okay. I think over-the-counter non-steroidal anti-inflammatory medications. I think stretching. I think anything that's going to low impact contribute to muscle strength and stability.
Got it. And again, that's one of those things where, as we're talking about the patient journey, at what point, okay, I've been icing my knee for a week, I'm taking the over-counter medication, when is it time to actually make an appointment?
I think when it bothers you enough that it's affecting the things that you do.
Yeah.
If you don't really notice it throughout the day, it hurts a little bit at night, and you don't really think about it much, then it may not be time yet. But once you notice that you're walking different, you're not going to play basketball or doing things you want to do, that's when you should make an appointment and start looking into things.
And we're talking about making an appointment with your primary care provider, and I know we're going to put the link, Sarah and Sierra are going to put that link in the chat eventually for our live audience to help you out on that patient journey. Another question that came in ahead of time, there are some really good ones here. Is there such a thing as too young or too old for knee replacement?
Yeah, that's another tricky question.
Yeah.
I think, at least in my practice, can speak for my practice, a lot of it comes down to quality of life and helping patients understand, if you've got a terrible joint that's destroying your life at 20, I could tell you come back in 50 years after you've wasted the next 50 years of your life with a bum leg, and I'll talk to you about getting your knee done. Or we can talk about, hey, listen, we may be doing this earlier than most people would, but it's probably going to give you the next 20 to 25 years of your younger, active life back to you. And again, I think that comes down to personal preferences and sort of assessing your own goals in life. For me in my own life, it's preserve quality now.
What do you guys think? I mean, same thing. When you're being approached by a patient that, hey, am I too old for this or too young for this?
I would agree with that.
Yeah.
I think it's so individualized based on how old somebody is and what activities they do, what they enjoy, and it's getting you back to your quality of life. So if you're young, like Dr. Ashby said, it may be a little earlier than some people would, but at the end of the day, if you can get quality years and then enjoy the things you do, I think it's worth it.
Yeah, I would say there's also other procedures available that are not a knee replacement, but they're more tailored to the pathology. For example, like someone may have like just an isolated area of cartilage wear, but the rest of the knee looks fine, and they're on the younger side. So instead of doing a knee replacement, what we can do is we have a procedure called an osteochondral allograft transplant, where essentially you basically get almost like on a transplant list, and then somebody who passes away with a knee that matches that person's anatomy, we can basically take a cartilage plug from that cadaver and then plug it onto the person. Another one that we have available now is an autologous chondrocyte implantation, where it's a two-stage surgery where we first go in, harvest some cartilage, then we can send it to a company that expands it onto basically a cellular matrix, and you come back for a second surgery where we basically open up the knee, find that cartilage defect, and patch it up with your own cells.
Wow. So a lot of, and to answer the question, like you said earlier, like if they're a younger patient, there are options.
Yes.
You don't need to go for a full knee replacement. The partial could work.
I think that's one thing that's been really nice working with Banner. We have, as a surgeon here, I feel like I've got access to their investments into state-of-the-art, cutting edge technologies. They've taken that very seriously. And then I also have really good colleagues, and for that younger patient that comes into me, even if it is affecting their quality of life, a lot of times I'm looking at that and I'm saying, hey, I want you to go and talk with Dr. Buerba after this, because I want to make sure that between he and I that we have the best option for you, whether it's some sort of a cartilage procedure, some sort of like a meniscal procedure, whatever it is, or maybe it is what I have to offer, but at least I have a colleague that we can go back and forth and try and get the best thing for the patient.
Okay, we got another live question coming in. Looks like a non-operative question. What do you guys think of red light therapy? Have any of you guys tried that or heard any feedback from your patients?
I'm more into green lights. I'm not a red light guy.
Anybody? No red light therapy?
I don't have any experience.
Look at this. We got one coming in live. And Sarah, Sierra, I'm going to put no pressure on you, but I'm going to read this as you're typing it. Is it normal to still have pain 5 months after surgery?
I think it depends on what surgery, but if you had a full knee replacement, it can be normal.
Okay.
As we talked about earlier, you'll continue to see improvements up to a year. So your body's adjusting to a new normal. Your knee is now functional, but it's not the knee that you were born with. So it takes time for your body to kind of acclimate to it. And some people may recover slower than others. So it can be normal to have pain that far out.
Okay. Good.
I would say when it comes to ACL surgery, at that point, usually is maybe the patient struggling to really strengthen their quadriceps muscle, and that can really just affect the biomechanics of the shoulder, and the knee, and lead to some pain. So at that point, we don't get too concerned yet. We just keep working with physical therapy to strengthen, and usually that tends to improve.
When it comes to ACL tears, we were talking about it earlier. You know, those, especially for sports injuries, where I think in years past, again, we've seen an ACL tear career-ending sometimes, and now you're seeing athletes tear their ACLs, and there's even thought of them returning sometimes in the same season. Is that again due to the advancements in what we're seeing when it comes to ACL surgery?
A few things. I think ACL surgery has gotten better, but also the rehab has also improved significantly. Regardless, still, like, the big data studies show that even after an ACL tear, people are able to get back to playing sports, but sometimes getting to the same super high level they were at, it's very difficult to obtain.
But some do, and it's pretty impressive to
Yeah.
see, you know, some of those athletes come back from full ACL tears. Okay, another live question coming in. Thoughts on genicular artery embolization? Wow. Anybody want to take that one on?
I like blood supply. I like blood supply. I like blood flow. So the more blood flow that I have in a knee, the happier I'm going to be with it.
Okay.
I don't have experience doing that procedure itself, but like I say, I've always been behind anything that's going to improve blood flow to the knee.
Okay. And then there were, you know, some questions beforehand that came in interesting related to surgery. When can I drive after surgery? And I know it's probably different for different surgeries, but if you want to get behind the wheel again, what's a good protocol for that?
I think, again, depends on what surgery.
Yeah.
It's a general rule of thumb, 6 weeks is a good estimate, but again, that depends on what surgery. But there's a few criteria that we want you to meet to be able to drive. One, we don't want you taking any narcotic pain medication. You shouldn't be driving with that. You have to safely be able to get in and out of a car, and you have to be able to drive safely. So once you kind of meet all those criteria, we tell you to maybe take the car out to an empty parking lot and see how you feel.
Okay.
But it's always best to ask your physician if they think it's safe for you. And then another thing to note is if you had surgery on your right leg, it could take a little bit longer.
Yep. What are some other questions you guys get most commonly after surgery when it comes to things people want to get back to doing? We had cold plunge earlier. We had, when can I get behind the wheel? What are some of those other questions that patients usually come to you guys with?
I get a lot about going back to playing golf, playing pickleball, essentially returning to normal levels of activity. And again, I'd mentioned something earlier about survival, and I think humans are good at it. And it says, hey, listen, ease into it, and if it feels good for you, then I want you to get back into it, and if it doesn't, back off because the healing's still happening.
Awesome. And as we kind of wrap this conversation up, I want to give each of you an opportunity to kind of shed light on what you're excited about maybe over the next 3 to 5 years in your field. We've already talked about how things have advanced in the last 10 to 15 years, how some of these surgeries have gotten even better. But let's kind of go around the panel and talk about what you guys are most excited about. Dr. Ashby, we'll start with you.
Oh, okay, yeah. Well, specifically with knees, I think the things that are exciting for me are some different ideas on alignment for the knees, and I think if I had to watch the trends and I had to watch the things that have worked out best in my practice, is that as we get closer and closer to restoring patients' anatomy, the patients are happier and happier with the product. And between the minimally invasive, muscle sparing, subvastus approaches to the knee, technology like robotics, which is allowing us to do what we want to do with the alignment, and implants that are designed to reproduce that, I think it's really exciting, and I think patients are experiencing a lot of improvements from that.
That's great. All right, Dr. Borba.
For me, I'm excited for the one-stage cartilage procedures. Because
one-stage cartilage procedures.
Yeah,
okay.
or that don't have too much of a wait time.
Yeah.
Because when you trying to get that osteochondral plug, you have to basically wait for the right match, and that can take months. And then if you're doing the chondrocyte implantation, that's 2 surgeries. So we're working now to hopefully just do like a one-stage procedure, 1 surgery, that there's no wait time, you can just do it.
Wow.
Industry's working on that, and I think we're going to be able to have better cartilage solutions in the next few years.
Okay, 2 great answers. No pressure on you to bring us home here. What are you most excited about in your field?
I think specifically in knee replacement, 2 things. One, as Dr. Ashby echoed, and I think technology. We've seen technology improve every aspect of life that we live in, and it's no different with knee replacements. As technology gets better, we're learning that we can put these implants in more anatomic or native positions. So in the position that you were born, we can put your knee back at that, and that's helping optimize your recovery.
Wow.
And then the second thing is, as we get better at doing these and people's recovery gets quicker, we can start doing a lot more of these surgeries as an outpatient. So 15, 20 years ago, if you had a knee replacement, you'd be stuck in the hospital for a couple of days.
Yeah.
Now you can have a knee replacement in the morning and be home for lunch.
That's crazy.
So as those advances keep honing in, I think patients will only continue to have a better recovery.
Just don't drive yourself home.
Exactly.
After surgery. Yeah. Doctors, thank you guys so much. I know your time is so valuable and great for you to share this information with this audience. And we want to thank you for watching and participating. Important reminder here, this will be available to stream and share with those you know that will find this information valuable. So just use the link after the show to send it off. And again, if you're interested in making an appointment, we recommend going through your primary care provider, but we are providing some links for you in the chat there to start you off on your patient journey. We thank you so much for watching. Doctors, thank you again, and we'll see you next time.